Good afternoon, good evening. Thank you so much for joining us for the Mpox and Marburg briefing from AfricaCDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Joining us today as the main speaker is Dr. Ngashi Ngongo, the Head of Incident Management Team. And we are also joined by Dr. Jean-Maria from the IMST co-lead from WHO Afro. Also joining us is the Honorable Minister of Health from Rwanda, Dr. Sabin. Nsanzimana. I will now hand over to Dr. Ngashi to start the session. Over to you.
Thank you very much, Director Margaret Edwin, Honorable Minister, distinguished guests. On behalf of the IMST, myself and Dr. Yameogo, we have the opportunity again this week to give you an update on the situation of Mpox, both the epidemiological situation, but also some of the highlights on the response to date. With that, Director, if we can then go through the slide. Second slide. Yes, the main highlight since last week when we reported to you is that now we have 5 member states that have not reported a confirmed case in the last 4 weeks. I think that's Cameroon, Gabon, Guinea, Rwanda, and South Africa. And also that over the last 1 week, there is no new deaths that has been reported out of Central Africa. Also, we are happy to report that one of the major challenges has been the low testing rate. Now we can report a 37% increase in average weekly testing rate across the continent over the last 3 weeks. I think a lot of effort in the testing area, but we can see now the beginning of a positive result. Likewise, the test positivity rate has also increased. You remember that last week we were at 36%. Now, this week we are at 63%. But despite all that, we are also observing an increase in cases in 3 countries. That's Liberia, Kenya, and Uganda. We also like to report that there's a new case that has been reported in Europe out of Africa, that's Germany, on the 22nd of October. That was confirmed by the Robert Koch Institute. That is Mpox clade 1B, which is the same clade that is circulating in Eastern DRC and in East Africa. And finally, that we've observed also the concurrent increase in the number of Mpox cases in children, together with measles also in children below the age of 15, that is happening in DRC provinces, in particular in North Kivu and South Kivu. Next. Now, the situation, the cumulative situation from the beginning of the year up to week 41 is that we now account for 45,327 cases that have been reported, of which 9,114 confirmed and 1,014 deaths reported from 18 AU member states. But important, as you can also see in the table on the right, that Central Africa still accounts for the vast majority of these cases, which are 85.5% of all cases and 99.5% of all deaths that have been reported to date. But then when we compare the situation last year, that's the entire of 2023, we have observed more than 400% increase in confirmed cases this year, just to see how the situation has really increased exponentially. Next slide. Also, when we look at the situation as of week 41 now, we had 2,729 new cases that were notified, of which 1,001 were new confirmed cases. and 26 deaths. That comes to the case fatality rate of 1%. But it is important to also say that even that week 41, DRC and Burundi, those two countries accounted for 96% of all confirmed cases. And as we said before, we've seen 5 countries where, again, consistently, there have been no cases reported from those countries on week 41 as well. But when you look at the cumulative number of cases, I think children below 15 years account for 38% of cases, and the males account for 53.5% of cases. On the laboratory performance, we've observed a testing rate of 58%, which represents, when you look at the comparison over the last 6 weeks, is about 11% increase on average. But when you look at the last 3 weeks, as we said before, it's about 37%. That to show that all the efforts that we are seeing in the area of laboratory testing are also now trying to show some good results. Likewise, on the positivity rate, I think we've increased also from 36.5% last week to, no, the week before, to the week 40, to 63% on week 41. Next. We are also looking at surveillance. I think one of the areas that has remained really a huge challenge. You remember in the Mpox plan, we had planned really to work around 20 contacts for each of the each confirmed case. That's the target. But then in the plan, we're aiming by December, at least during this the first 3 months of the response, to be able to capture at least half of that, which is 10 contacts per confirmed case. But we have observed that up to now, out of the 18 countries that are affected, only 4 countries have listed an average of 10 contacts or more per confirmed case. That to show that contact tracing still remains a huge challenge. As you can see that for the week 41, out of the 1,001 confirmed cases, only 696 new contacts were listed. That's really where we have a problem. But most importantly is also to note that some of the countries like DRC, where you have the numbers coming, and other countries like Gabon, Rwanda, Nigeria, have all listed less than 5 contacts per confirmed case. It is really an area where the gaps are still notable. Next. Now, when we also look at the number of Mpox cases and also the cases of measles that are reported in the DRC, there's a very interesting trend that we see that both outbreaks, I think the number of cases are increasing, starting from week 19 onward. I think that is a trend that is really of great concern. And the data we present here is from Sud Kivu, but it's a similar trend that's also observed in North Kivu as well. But then the most important for us is that this risk of measles Mpox co-infection might be exacerbated in treatment centers if we do not strengthen the IPC measures in those institutions. Next. Now, looking at the laboratory performance, what we are seeing that over the last 3 weeks, we have seen an increase in the rate of laboratory testing. We started with, on week 39, where 39% of the sample, 31% of the samples that were tested, and then week 40 we reached 38, and now week 41 we've reached 58%. For the first time now, since the last 4 weeks, we've gone above 40%. I think that's very encouraging. And on average, that's about 37.5 increase on weekly testing rate that we have observed. Now, some of the contributing factors to that is that training has been going on really in all these countries, in particular in Burundi, Central African Republic, Congo, and DRC, where we have the majority of cases. Training on sample management has been going on, and also on qPCR and GenExpert testing. In addition to that, we've also been working to strengthen the sequencing equipment. I think at least 7 sequencing equipment have been also made available, especially in Burundi, Central African Republic, Ethiopia, Kenya, Mauritania, Sierra Leone, and Zimbabwe. Also, we have been distributing the cartridges, 7,000 GenExpert cartridges that have been distributed, also contribution of both AfricaCDC and WHO, and 11,000 qPCR tests also sent to Burundi, Cameroon, CAR, Congo, Cote d'Ivoire, DRC, Kenya, and Liberia, Rwanda, and Zambia. I think those efforts to improve on the skills, improve on the equipment and the maintenance of the equipment, and also make the kit available are contributing to the positive changes that we observe on the laboratory performance. Next. On the vaccination front, all the category 1 countries that are listed in the continental plan have already prepared and submitted their vaccination plan. That is DRC, Nigeria, Rwanda, Central African Republic, South Africa, and Cote d'Ivoire. And we have at least 2 countries that are already vaccinating, that is DRC and Rwanda. And we are also informed that Nigeria has planned to launch its vaccination on October 29, which is just 5 days from now. You remember the last time we reported that they had intended to launch the vaccination on the 22nd, but they reported that by 1 week. On the availability of vaccine, we are also happy to say we have 5.6 million doses of Mpox vaccines that have been confirmed, of which 2.5 million of MVA, and 3 million of the LC16 from Japan. Now, in terms of availability in October, it's about close to 900,000 doses of MVA available in October, and also another 700,000 that are potentially available in November. That's about 1.6 million doses that we have. I think enough, at least for the moment, to cover the plans that we have received. Next. Now, just reporting on the status of vaccination in the DRC as of yesterday, what we noticed that in North Kivu, the province that started before, they started on October 5th, the vaccination coverage is 138%. That means they have exceeded the targets that they had planned. Sud Kivu, which also started on October 6th, they have also reached a vaccination coverage of 109%. And we have Chopo that started on the 7th of October, have reached 91%. And then we have the 3 other provinces that just started later, starting from 15th and 17th. That's Sankuru, Sud-Ubangi, and Equateur, where vaccination is still ongoing. The overall performance is about 85% coverage against the cumulative target. But the key messages that we are getting from there is that the acceptance of Mpox vaccination is quite high when we look at the picture in the 3 provinces that started before. And we are still also monitoring the situation in the 3 provinces that started after. Also happy to report that vaccination has also commenced in the congested settings, in prisons, and the IDP camps in North Kivu, where cases of Mpox have been reported. Now, the priorities on vaccination moving forward is the vaccination in Kinshasa. Preparations are quite advanced. The tentative date is on November 5th. That is just 2 weeks from now. Now, working on all the important inputs, in particular, the availability of vaccines. They need at least 160,000 vaccines expected to vaccinate Kinshasa, and also the funding to allow them to launch the vaccination in Kinshasa on November 5th. But another also priority on vaccination as we move forward is the vaccination of children. We are working currently with the NITAG to also push the recommendation for the use of MVA vaccine in the population of 12 to 17. I think that's an area quite advanced because WHO has already given the pre-qualification for the use of those vaccines in those categories. Just the national authorities that also have to embrace this to allow the vaccination of children to start. Next. On the pharmacovigilance, I think given that Mpox is a new vaccine, I think there's a partnership that has been established between AfricaCDC, WHO, CEPI, and PAST. I think we've started with the DRC. I think that's why we have the Minister of Health and also the University of Kinshasa joining the partnership to be able to support the activities on pharmacovigilance with the introduction of vaccines. Now, after DRC, we'll be moving very soon to Rwanda because that's the second country that is also vaccinating right now. And based on the experience of DRC and Rwanda, we'll expand to the other countries as they join also the vaccination on Mpox. Next. On the IPC, I think WAKE has been working on being on three fronts. One is the capacity building of healthcare workers and community health workers in Burundi, in Cameroon, in CAR, in DRC, in Kenya, and Uganda through an integrated approach that brings IPC both with case management, as we know that it's important that we strengthen IPC in the treatment centers, but also linking it to surveillance with laboratory and RCCA activities. Also, we have developed a database of all the IPC focal points in the affected countries, starting with DRC, Guinea, Kenya laboratory, Liberia, Nigeria, Rwanda, and Uganda, to be able to know in all the health facilities who are the IPC focal points who have to be trained, and also the performance of those facilities on the key IPC indicators. In addition to that, I think we've also been working to develop all the guidance documents, both for home care, for health facilities, and also for schools, to ensure that we have all the tools that are needed to improve the quality of IPC in those priority settings. Next. Finally, I think in summary, what we like to say that challenges are still considerable, especially in the area of surveillance. We've seen in laboratory some positive changes in terms of improvement in test positivity rate and also on average testing rate. We are very much delighted to see that the introduction of Mpox vaccine has been very well received in both DRC and Rwanda with a high acceptance rate. It's also important to note that all the high-risk countries have now completed their plans, and they are in the preparedness mode now to introduce the vaccine. And also on the area of children, that's perhaps one remaining challenge that we need to address to improve the access of children to Mpox vaccines, looking at both the regulation, but also even the issue of access, because as we introduce access, the number of children needing to be vaccinated is much higher than the quantity of vaccines that have been played so far. And finally, is that we are really working very hard to push an integrated response to make sure that there's a balanced focus on different pillars. As we improve on surveillance, we also work on testing, we work on IPC together with vaccination, and for which it is extremely important that we maintain the current momentum and also the coordination of effort of all the partners as it is happening now. I think that is the summary of what we wanted to share today. I think Dr. Yameogo and myself will be open to receive the questions and comments from the participants. Over to you, Director.
Thank you, Dr. Ngashi. We'll now hand it over to the Honorable Minister to give his updates from Rwanda. Over to you, Honorable Minister.
Thank you. I hope you can hear me and see me. Good afternoon, good morning. I'm happy to join again the AfricaCDC weekly brief on Mpox and Marburg. So I'll be talking about Marburg because Mpox has been extensively explained by Dr. Ngashi. And I'll be brief since we have a limited time. But I want to start by saying that it's now a month since the first case of Marburg was confirmed in Rwanda. It's an outbreak that we are controlling. We've had almost 9 days without new case, but yesterday, one of the health professionals has been treating and taking care of all the Marburg cases. We've had a total of 63 so far. So one of the teams that started with this treatment center tested positive. The health professional is doing well. He actually had received a vaccine a few days ago, and we see that the outcome, given that layer of protection, will be much better. But the positivity was confirmed with some symptoms, but not as for usual presentation. So we believe that having received this vaccine, we don't know if the infection was before or after, but again, this is an important information to share, that even if we had this period without new case, this one happened. The good thing is that the person has been in the treatment center and has no contacts outside the center where they were also living together in high infection prevention control protocol. So that is the case we had last night. And we also want to report that cumulatively we had lost 15 lives. Most of these are health professionals, as presented in the previous briefs. But we also had 46 recoveries, which is also a good number to talk about, given the traditional statistics of higher fatality rate for this virus. Overall case fatality rate is 23.8%, which is high compared to the previous presentation we had on Mpox, but this is the lowest you could get in terms of compared to previous Marburg outbreaks. But again, these are lives of people that we are aiming to protect, any life that catch this virus. So we've done, when we continue to do testing for everyone presenting symptoms, but also we have a big number of contacts we are following. The number of contacts is reducing. The maximum we got was over 1,000, and now we're getting towards half of that, given the period of follow-ups that is exceeding 21 days for most of the first major contacts we had within main cluster in the hospitals. The other key information I want to share is that we managed to trace back and find that this infection this outbreak came from a zoonotic origin. And we were able also to find the cave where this particular fruit bats were living with human activity, particularly mining, that was taking place, and that's where we found our index case. This is information we shared on Sunday during the briefing when Dr. Tedros, Director General of WHO, was also visiting in Kigali. And we now know where this importance of One Health and zoonotic animal to human transmission can be. And that is the current focus for us, to ensure that these fruit bats living in caves are not interacting with humans, but also we ensure that what happens here is very important information for public health, for science that can be useful for other parts of the world where these species are living. It's important for One Health and also important for public health in general. The third update I want to share is the sequencing. I know that this has been discussed before, and we had promised that we provide the sequencing results from Rwanda, which we did. So we actually identified that the sequence we have is very close to what has been reported before in the region, and that it's very close to the zoonotic origin, which again, the sequence result confirms what we had observed by doing other laboratory and epidemiological tracing to the index case I just explained. So the work being done is to do more surveillance, ensuring that this index is an eye opener for future preparedness. We still have 2 patients who are actively being treated, and we have had a decline of new cases and deaths. In the last 10 days, there was no single death, no death. And the new case we had in the last 10 days was the one I mentioned before. So 1 case in the last 10 days. It's a good trend. We cannot rule out the presence of contacts that may be reaching some symptomatic phase and identified, but the contacts also number is reducing with time. And we are actively making sure we assess and investigate all these minors who have been in contact with the bats. That's a current activity happening in Rwanda with our partners from AfricaCDC, from other organizations and institutions. And we continue to vaccinate people. We've reached more than 1,000 vaccinations using the Sabin Vaccine Institute, which we've discussed earlier before. And we continue to explore other advances in science on what we can learn from this outbreak, but ensure also that we control, fully control, which is almost reaching at the time where you are trying to find the last one or one that is probably hidden somewhere, which is different from the first weeks when we were still having a lot of contacts and symptomatic cases. So it's better, much better than before. It's a positive trend. It's an effort. It's a result from efforts of different people. And we continue. It's not yet over, but it's a great trend that we're seeing that Marburg is being controlled. So these are the few updates I had for today. Happy to get some feedback, questions, comments. But I know most of you have been part of our other briefs and updates, as well as our daily posting on the Ministry of Health of Rwanda daily information. So thank you very much. I pause here.
Thank you, Honorable Minister. Let's move to take questions from the floor. Stephanie from New York Times, you have the floor.
Thank you very much, Margaret. My question is for, I guess, for Dr. Ngongo. I was wondering if, I have 2 questions actually. Could you talk a bit about what you think accounts for this sharp rise in case positivity? What's going on there? And secondly, could you describe a bit what you think is responsible for the lower rates of contact tracing in the areas that are still having trouble with this? Is this a human resources issue or a logistics issue or the stigma around this particular infection? What do you think is preventing the countries that still have quite, numbers below your target threshold from getting there? Thank you.
Thank you. Let's take the next one just before he comes in. Kerry from Health Policy Watch, you have the floor.
Thank you, Margaret. I have two questions also. As I'm interested in the interaction between Mpox and measles. What is causing that? Does one make you more predisposed to the other, or is it just because people are going to health facilities and being exposed to the other disease? And then the other one is for Dr. Nsanzimana. I just wanted to know, in your outreach to the miners, how do you are you going to close those caves where the bats are, or are you going to tell them how they could protect themselves? Thank you.
Thank you very much. Let's take the last question to the Honorable Minister. Minister, you have the floor.
Thank you, Margaret. The question about the caves and what we do about it, I think, is important to note that we want to make sure that there's no interaction between these fruit bats and humans. What we noticed is that these bats have been living there for several years until the mining activity, human activity, actually gets in this contact we're talking about. So what we've done since we confirmed the connection, which was last week actually, we immediately stopped the activity within that particular site. And what is being done is to follow up on the people working there to make sure they don't develop the disease because they have been exposed, and to make sure also there's no further exposure or further movements in that area. So that is what has been done, but it opens for us another area of surveillance for this particular species. So we brought together different teams from vets, from epidemiology, genomic surveillance, and lab diagnostics, testing these animals, but also people. So it's very important for the scientific community on both from animal perspective and humans, but also environment. So that is why I was underlining this point, known as One Health, that not only this particular species, but also for any other animals that are potential to cause disease to people. It brings also the element of of climate and health and the human activity that we'll be exploring maybe in the future discussions. Thank you.
Thank you. Over to you, Dr. Ngashi, for the other questions.
Yes, thank you very much for those very interesting questions. I think I'll start with Stephanie's questions about what can explain the rise in the case positivity rate. I think that is what is normally expected, is that at the beginning, the frontline health workers that identify these cases usually struggle with the case definition. The more they get experienced, I think they also try now to refine more the selection of those cases that they feel meet the criteria. I think zooming more toward those that are much closer to the Mpox infection, I think that is one thing. And then the second, also remember when we reported that on the laboratory side, there was also a training of on sample collection and sample management. I think that has also contributed to improving the quality of the samples, you know, from the point that they are collected, the way they are transported and brought to the laboratory. And then it is the improvement of those two elements, the quality of the samples and also the skills of the frontline workers, that explain that the improvement and case positivity rate. The question of contact tracing, it is very much linked to human resources. Human resources, first of all, to get enough people, enough experts to be able to establish the contact list. That is why it starts. And then the second is also the fact that the community surveillance piece has not been really very well activated because of the lack of involvement of community health workers. That also explains the fact that even where they have been identified, you saw that it's about 34% of the follow-up of contact, meaning there are not enough people to be able to follow them and see what happens afterwards. Now, with the deployment that both WHO and AfricaCDC are now making of epidemiologists, even the repurposing of some of the epidemiologists that were supporting other programs like polio that are being redirected now to go and support Mpox, I think we'll see improvement in those areas. In addition to that, we are also now working to also mobilize community health workers to support the home follow-up of contact tracing. I think those interventions, we hope that bringing more experts and also bring community health worker into this space will contribute to improving the situation as it is now. The question of Kerry on the interaction of measles and Mpox is a very interesting one. First of all, what is happening that the overall coverage of measles in those areas is very low. In Sud Kivu, there are about 55% measles first dose coverage. You see that you have the accumulation of this cohort of children that have not been vaccinated, and then it is the vulnerability that's already there, that they are vulnerable to measles. Then we expect really these non-vaccinated children to catch measles when it happens. But in addition to that, it's also that these are also areas that we have a high rate of malnutrition, also having an explanation on the immunogenicity, on the immune system of those children, also weakened because of that, then making them also vulnerable to both Mpox and also measles. Now, the question that is now left to understand is the interaction between the two. I think we haven't yet established that the fact that you get measles then increase your chances of getting Mpox and vice versa. I think that is still something to understand. But the first explanation is just the vulnerability related to the low coverage of immunization on one side and the malnutrition or high malnutrition rate on the other side, that they can explain what we see. I don't know, Jean-Marie, anytime that you have anything to add, just feel free to do that.
No, it's okay. We are working to improve the contact tracing strategies. And as you said, we managed to involve other partners, community health workers, also some NGOs like the International Red Cross, volunteers that now deploy in the field. And what we observe is the underlying factors that can explain why we are getting at the same time more measles cases, and also the Mpox is still also something that affect the same target populations. Know that most of the cases are children, and so that's where we keep reporting. And finally, we have increased also the surveillance strategies in terms of data collection, and also we involve more health workers in terms of data analysis. Over.
Thank you very much. Let's take the next questions. Carmen from Politico, you have the floor.
Thank you so much, Margaret. So I wanted to ask the Honorable Minister from Rwanda, in terms of the vaccine, what are the sort of like outcomes that you're looking at in the trial? Is it is the vaccine thought to just make sure that people who get vaccinated don't progress to severe disease, or is there a potential that it could actually block infection? Sort of like what is the what are the expectation, or at least the sort of like endpoints that you're looking at? And I was wondering if you also can give us an update on the antiviral, the therapeutics that are being used. How is that going? Do you have any data on which one is performing better in keeping people alive and helping them get better faster? And then in terms of the Mpox vaccination in children 12 and on over in the DRC, I was wondering if you could, Dr. Ngashi, if you could clarify a bit like what exactly is needed now locally to start that vaccination, given that indeed, as you said, the WHO has pre-qualified for that age group. What's missing before, you know, children 12 and above that can start getting the Jynneos vaccine? Thank you.
Thank you. Over to you, Honorable Minister.
Thank you, Carmen. These are very important questions. I think for vaccines like this, the first expected outcome is actually to make sure people who may be in contact or contract such disease or pathogen do not develop severe disease or potentially be able to build immune response to protect themselves. It may not mean that you are not going to get infected, but it means even if you are infected, it doesn't get to develop a severe disease, as you've seen in previous outbreaks and vaccinations. It's almost that the first main outcome. But for this particular case that I mentioned, we may not. It's still too early to know. Was it the vaccine efficacy with a certain limit that this case is going to be complications, or are we talking about a disease that was already developing, contact developing before even the vaccine was provided? So that's why I just give these highlights, but I can't for now tell, because we need to do also some testing on antibodies. When was it developed? How long does it take? So it's that time that we'll need to keep sharing and updating ourselves on this. Second, on therapeutics, we've used two types of therapeutics in trials, remdesivir, post-exposure prophylaxis, and also we used monoclonal antibodies that was in a small quantity. It's not like a big sample size that we will say we've determined how it works. So first was for compassionate use in an emergency situation, which now is switched into this protocol we developed together with WHO on therapeutics. So what you're observing on field is that these two therapeutics are helping. We've seen some great outcomes. That the reasons may be different, but I think one of the reasons is that we have these new tools that were not used in previous outbreaks. Secondly, is that the age group of people we are treating are quite young, and we've seen that this disease also, the outcome depends on other factors, including the age, including the presence of other comorbidities. It includes also probably the amount of virus exposed, because the early cases we had were providers who have been in ICU, dealing with a lot of fluids, and also managing a lot of contacts, probably with several amount of viruses than later on, which is seen also in the lab testing with the viral load, or this what we call city values, depending on the amount of virus found in someone's body, also depending on the level of exposure.
Okay, I see we are back. I'll now hand it over to Dr. Ngashi to respond to the last question that was asked. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. I think Carmen's question was about Mpox vaccination in the 12 to 17 cycle, what is missing? Just to say that things seem to move in the right direction. What was awaited is WHO pre-qualification. I think that's changed the whole thing. We hear that the National Immunization Technical Advisory Committee that was supposed then to endorse that and make a recommendation to the minister to start vaccinating met last week on Friday. We are just waiting for that recommendation to be released. From the what we hear already that it's like there was no really objection or resistance to that. That should go ahead. Then as soon as we have the recommendation from the NITAG, then the ministry will give the go-ahead for the vaccination to start. That's what we are hearing, and that I think we should go ahead with that.
Thank you very much, Dr. Ngashi. I'll move on to the floor to take the next question. Dorcas from BBC, you have the floor.
Good evening. Hello?
Good evening, we can hear you.
All right, sorry, I'm just confirming. So Uganda has confirmed its first Mpox death. We've seen media reports from yesterday and today. I don't know if this has come to AfricaCDC's attention. And we also understand that this is a person living with HIV. So my question is, besides the confirmation, is what does AfricaCDC recommend in terms of vaccination and treatment for people living with HIV? Second, we know that tecovirimat, the therapeutic, is available in South Africa, and it has been used for treatment for people with clade 2. So will this be made available to other African countries? Yes, and then also for the Rwandan health minister, you mentioned that you are working on sequencing. By any chance, is there any likelihood that this strain of Marburg may be linked to the outbreak in Tanzania? And also, in terms of what you're doing for the trial, are you looking at the efficacy or the safety of this vaccine?
Thank you, Dorcas. Let's take one more question before the response. We have Priyanka, you have the floor.
Thank you so much for taking my question, Margaret. My question is for Rwanda's Health Minister, Dr. Sabin. I was wondering, one, if there's additional animal surveillance that's already ongoing or happening in nearby caves or other bat populations, and if you could tell us a little bit more about that. And about the index case that's been linked to a particular bat population and cave, is it far, this location, is it like fairly far from Kigali? Just curious on that front. Thank you.
Thank you very much. Let's take the responses from Dr. Ngashi. We still don't have the minister. When he comes in, he can respond. Over to you, Dr. Ngashi.
Yeah, thanks, Director. I think Dorcas' question about vaccination in people living with HIV, what the science is today, that there's no restriction for vaccinating people that live with HIV. That's the reason why even South Africa has also made its vaccination plan and have requested for Mpox vaccines to vaccinate them. We can also look at the report from DRC. That's something that was not presented. We might present that next time. That among the people that have been prioritized for vaccination, key populations are in there, and the people living with HIV are also a priority group for vaccination. Just to say that that is something that is taken care of. Now, on the tecovirimat, tecovirimat was used for clade 2, where it was shown to work. And South Africa has got clade 2, it worked. But there is a study that was conducted in the DRC with Prof. Muyembe and his team to also assess if tecovirimat is also effective in clade 1. The conclusion of that study showed that it wasn't. I think that's the reason why there are many ongoing clinical trials to look at other antivirals rather than tecovirimat. That explains why it's not recommended. In Uganda, that we are talking about, Uganda is dealing with clade 1B. For that reason, I don't think it would be recommended now, but tecovirimat still remains a drug for clade 2 in West Africa, where we have clade 2 that is circulating in Nigeria, in Ivory Coast, in Liberia. In those countries, AfricaCDC, WHO are working to really mobilize the tecovirimat to be used in those countries for the case management of clade 2 cases. Over to you.
I asked also about the death that Uganda has reported.
Did you get that, Dr. Ngashi? Could you repeat your question, Dorcas?
Yeah, so Uganda has also reported its first death. That was yesterday, I believe. Has this come to Africa CDC's attention?
That's from
Dr. Ngashi?
Yes, we have the information. As you know, the way we operate, we wait for the official submission of the report from the government to us. It just happened yesterday. We have that information already. We did not include it today for two reasons. One is that we are presenting data for week 41. And secondly, we are still waiting for the official submission from the government before we can take it in the public domain. But we have the information already.
Thank you.
Thank you. Let's take the last question from John Songo. You have the floor. John, can you hear us?
Oui, vous m'entendez aussi? Est-ce que vous m'entendez?
Oui.
Merci.
Oui.
Merci beaucoup. Je voudrais poser mes deux petites questions. La première s'adresse au docteur Nsanzimana, ministre rwandais de la Santé. Je voudrais savoir si, avec les autorités congolaises, il y a eu des mesures, des ripostes contre cette maladie. Conjointement aux frontières, vu que, par exemple, via Goma, via la ville de Goma, il y a des échanges qui se font, entre les populations d'un côté du district de Rubavu et de l'autre côté de la ville de Goma. Est-ce qu'il y a des mesures qui ont été prises pour éviter que ces virus de Marburg ne se propagent jusqu'en RDC? Deuxième question s'adresse au docteur Ngashi. Je voudrais qu'il essaie de nous expliquer comment est-ce que il y a la prise en charge des victimes, donc des personnes qui ont contracté le Mpox, mais aussi si on vaccine quelqu'un qui a déjà le Mpox, comment est-ce que la vaccination peut réagir face à un individu qui a déjà contracté le Mpox, mais qui est vacciné contre le Mpox? Merci beaucoup.
Mercy, over to you, Dr. Ngashi.
Margaret, I think we do have a translation for John Songo. I could respond in French, but if there is translation, I can then continue in English, and then the translator will do that.
Yes, we have translation.
Oh, okay, thank you. Yes, John, I think the first question was on Rwanda. I don't know if the minister will still come back and reconnect, but what we can say briefly is that there is cross-border surveillance that has already been strengthened on both sides. I think that is going on. In addition to that, the DRC has also prepared already a plan for the response to Marburg in case. That's how there's already a preparedness plan, which include that cross-border surveillance. Just to say that there are some activities that are already going on the preparedness side on this side as well. And then the second question was on the treatment of Mpox cases. I think that is what he was asking. We don't have tecovirimat, but remember that the problem with Mpox, the complications comes from the infections of the skin lesions that can then migrate to cause encephalitis, to cause pneumonia, to cause septicemia. I think that is why there's a package of standard treatment. The only missing piece in that package is the antiviral because of the failure of tecovirimat. But everything has been put in place to alleviate the pain, to keep the skin lesions clean, and also antibiotics in case of infection, to really reduce the mortality among those patients. And the response is quite good. You can even see in Burundi where there is no tecovirimat is not there, but the treatment is just based on what I've just described, that mortality is 0. I think just to say that even the current standard treatment is responding also very well. And then finally, the question about the vaccination of somebody who is already infected, I think that that happens, especially when it comes to the vaccination in post-exposure prophylaxis of the contact of a person that might have already been infected. I think what we know that there is still some advantage to that although at that moment that vaccination is not going to prevent the infection, but that vaccination is going to prevent the severity of the disease that will be linked to hospitalization and death. I think just to say really that it still remains, there are still some positive benefits to be vaccinated, especially what happens when people have already been infected but they don't have symptoms yet. They get vaccinated, and then a few days after they develop the symptoms. I think there are still those positive benefits on the severity and the risk of mortality that they take advantage of.
Thank you very much, Dr. Ngashi. And with that, we have come to the end of the briefing for the day. We apologize for the technical difficulty that we had. I will now invite Dr. Ngashi and Dr. Jean to provide a last word before we close. Over to you, Dr. Ngashi.
Ok, bien. Je vais balancer avec la langue. Je voulais dire que nous continuons toujours avec cette réponse coordonnée. Nous comptons sur l'engagement des différents pays. Je pense que nous avançons ensemble et que ce que nous avons déjà franchi, que ce soit pour la réponse au Mpox que pour le marbourg, c'est un bel exemple de collaboration. Et je voulais encore rappeler la question de l'approche une seule santé, qui est extrêmement utile parce que le ministre de la Santé du Rwanda l'a démontré qu'il faut que nous travaillions avec les 3 secteurs, humain, animal et environnement. Et ça, c'est un élément important que l'OMS et AfricaCDC on met en avant lorsqu'il s'agit d'une réponse. Et finalement, je voulais encore inviter l'ensemble des journalistes à être nos porte-parole et nos messagers. Il faut passer les messages, il faut passer l'information et la bonne information aux populations, parce que c'est ensemble que nous allons venir à bout de cette épidémie qui est en cours. Merci à tous.
Yes, Director, just in following up with what Dr. Yameogo just said, first of all, we'd like to thank, I think, all the participants for the continued interest really in getting updates on the Mpox response. And also, secondly, we'd like to thank all the partners that have continued to support, I think, the effort of really getting this outbreak under control. It is true that now we have started seeing some positive results, which give us hope that if we can keep the foot on the accelerator, maintain the momentum, I think we should be able to see much better results in the next 2 to 3 months to come. We're struggling with where the 2 main challenges were related to surveillance and laboratory testing. We see already some positive changes on laboratory testing. Although we haven't yet reached the target of 80% testing rate that we set ourselves, but we remember when we started, we're below 30%. Now we are talking about 58%. That's double, I think, where we started. It is very encouraging result that we maintain. If we maintain the current effort, very soon we hit that 80%. Important because the sooner you identify these people and get them out of the communities, the better to stop the transmission. Because what was happening, they were staying much longer undiagnosed, and therefore transmission was ongoing. We are also hoping that the current effort on surveillance are also going to help us. And the point that Dr. Yameogo just mentioned about One Health is critical. is really essential to make sure that we connect the animal surveillance with environmental surveillance and human surveillance to be able to control not only Mpox or anything else which might come that we might have missed. As we just presented the data on measles, one of the good reasons is that the strengthening of surveillance on Mpox is also helping us to pick those other conditions. That's something very important. And also that as we present, we are very much aware that we need to maintain an integrated approach to the response. So it's not only vaccination, it's IPC, it is surveillance. Really that integrated approach is something critical that will continue until we get this under control. But what is important though is that we've just launched about an hour ago the financial tracking tool that has just gone live. I think we'll get time to present that last time. We still need a lot of support. We still need a lot of resources to be committed. We still need to work together to get more vaccines, more IPC materials. It is something that will continue really advocating with our partners to also maintain not only the support, but also continue also providing even more support to get us to the finish line. I think with those few words from both of us, we'd like to thank everyone for participating in this conference and then for the ongoing support to the response. Over to you.
Thank you very much. We'll see you next week. Thank you.